Christy Adams is a registered nurse and has been the coordinator for the UC Davis Health Trauma Prevention Program since 2007. She has 17 years of experience as a clinical nurse and has worked in the emergency department, intensive care unit, and as a flight nurse with the Life Flight Helicopter Air Medical Program. Christy focuses on building capacity through collaboration and empowering underserved communities to improve safety. She's a master trainer for the Stepping On and Matter of Balance Senior Fall Prevention programs and co-leads the Stop Falls Sacramento Senior Fall Prevention Coalition.
Again, as Simona mentioned, if you do have questions during the presentation, if you could please put those in the chat, and then I'll leave some time at the end for question and answers. But first, as with any presentation, we always start with the data. What's the background? What do we know about falls among older adults? Well, we do know that 1 in 4 older adults or people in the United States over the age of 65 report falling at least once a year. Now, those numbers are actually from a national survey that's called the Health Behavior Survey. That's a random digit dial phone call, but it is fairly representative of population in the US that is living independently at home. So 1 in 4, 25%, that's actually a fair number of individuals when you think that in the next decade, about a quarter of the population in the US is going to be over the age of 65. We also know that of the individuals who do report having fallen, only about half or even less than half will talk to their doctor about that. And when we explore the reasons behind that, there are different reasons, but a lot of it does come back to there's a lot of fear around potential loss of independence. I think there's some fear for older adults who are living at home that maybe there's some concerns by loved ones or physicians that they're no longer able or capable of living independently. And so oftentimes we see that people who are falling are reticent to talk about it for those very reasons. And we really want to sort of switch that perspective and that paradigm and really encourage individuals and caregivers, family caregivers, to talk to physicians about a fall or concerns of falls, because we know that there's a lot that can be done to reduce fall risk. And until you're able to really delve into those individual fall risk, it's a little more challenging to figure out how to reduce them. So we also know that the direct medical cost of non-fatal falls in the US, and again, this 2018 data is the most current information that we have, but 50 billion US healthcare dollars are going into treating the injuries for individuals over the age of 65 who have fallen and either been seen and released from the emergency department, which is the greater percentage of them, or been hospitalized, some for a very long time. And not included on this slide, but we just know anecdotally and from some personal experience that falls in individuals over 65 do have a tendency to reduce mobility and independence, and there's sometimes that loss of mobility that comes with that from those injuries. So again, that tends to be one of the bigger concerns around falls in our older adult population. And last, I do want to point out that we know that roughly half of fall-related deaths in the US are due to head injuries. And I will add a note to that oftentimes those head injuries are from what's known as cerebral hemorrhage or cerebral bleeds, because those individuals are on some type of blood thinners, typically for either a history of a stroke or a blood clot or a heart irregularity like atrial fibrillation. And I'll talk a little bit more about that when we look at medications as fall risk and what we can do to address or reduce that fall risk. So we do know that fall risk and actually injuries increase with age. There's a number of things, as you can imagine, that go along with that because the aging process affects our strength. It does decrease our innate balance. Things like proprioception. There is a natural loss of bone mass, particularly in women post-menopause, and also, unfortunately, sensory deficits, hearing loss, vision, changes are part of the inevitable aging process that we are all facing every day. So I'll talk a little bit more about those fall risks as well moving forward. So when we talk about fall risks, we really focus on two different categories of fall risks, if you will. So some fall risks are non-modifiable. We know that there are certain things about an individual that is associated with an increased risk of falls, such as age. That doesn't, the difference being just because you're 85 doesn't mean you're going to be falling, but what it does mean is that more 85-year-olds are falling, if that makes any sense. So it's really not about an individual's age per se. It's just that we know as the body ages and all these factors that come with aging, more people who are older tend to have more falls and more injurious falls. Gender as well. Again, we know that there's a greater incidence of fall injuries among women. And part of this is due to, some of it is frailty and osteoporosis. That doesn't mean necessarily that women are falling more than men. It does mean that women are tending to get injured more. And again, that really goes back to the frailty and osteoporosis, osteopenia. We do know actually for hospitalized falls, men tend to have more severe injuries. And that's often due because they're more likely to be taking the high risk behavior, which some of you have probably seen this if you have husbands, fathers, or individuals that you're caring for that are still getting up on ladders, hanging Christmas lights, doing things on the roof where they should not be working. But again, men tend to take those higher risk behaviors than women. And so because of that, tend to have a little bit higher severity and injuries for hospitalizations. History of falls. You can't control how many times you have fallen in the past. We know that that is associated with an increased risk of falls in the future, and things like impaired cognition. Unfortunately, with Alzheimer's and dementia, in and of themselves are not modifiable. That being said, there are things that we can do to reduce fall risk among individuals who have impaired cognition. So moving over to the category that we'll be focusing on today, to be a little bit more optimistic on things, modifiable risk factors are those that we actually can sort of budge the needle on, things that we can make a difference in, even taking into account the aging process. So things in particular like strength and balance. It doesn't matter if you're 99 or 59. There is, you can always increase your strength and balance to some degree. Obviously, our bodies are not as resilient as they were when we were 20 and 30, but we do know that even though, you know, muscle mass and muscle strength continues to deteriorate with the aging process, we do know that it can be responsive to exercise, particularly balance, and I'll talk more about that. Vision, while the vision itself may not be modifiable, although in some cases like cataracts, yes, glasses and whatnot, again, we'll address that. Environmental factors, definitely probably one of the most modifiable things that we can do is the simple stuff around the house. And again, I'll address that. Medications and last, and again, this is not an exhaustive list, but really some of the big key, the key risk factors that we can do something about or can modify. And fear of falling is the last one that we talk a little bit about in this presentation. Other risk factors, which may or may not be modifiable, but they're a little more specific to individuals and typically related to medical conditions, vestibular dysfunction, and there's all sorts of factors. There's all sorts of diagnoses that affect our vestibular system that can affect our balance. Peripheral neuropathies, particularly with diabetics, where you lose some of that sensation in your feet or have hypersensation and a lot of pain. Postural hypotension, where you stand up and you lose consciousness or you get dizzy, and then cognitive impairment. Again, talking a little bit about the Alzheimer's and dementia effects on both executive functioning and particularly Parkinson's with the gait and the stride. So these specifically may not necessarily be largely modifiable, but there are things that can be done on a one-on-one with a care provider to reduce some of the risk factors associated with these conditions in particular. So I think one of the important takeaways for today that I would like to promote is the idea that there's no quick fix to prevent or reduce your fall risk. It really is a multifaceted approach that includes strength and balance, medication management, vision maintenance, and home modification. And more importantly, reducing a fall risk really is an individualized plan. And it really requires sort of a team approach, right? So you have the older adult who's got the fall risk, and working with obviously the individuals themselves, because no one knows our own bodies like we do, working with the physician around the medical conditions, working with a pharmacist, physical therapist, working with obviously a vision specialist, exercise, and really just the whole team of identifying what it is specifically about that individual that puts them most at risk for falls. Because like so many things with humans, from individual to individual, we're completely different, right? And so it really is an erroneous thought process to expect that fall risk is going to be the same across all adults, all individuals, and that, you know, there's one pill that can fix it all, so to speak. It really is the individualized fall risk plan that's important. And for some people, that's going to be pretty low key or pretty light. Maybe changing their exercise, being a little more active is going to be the key and what it's going to take. Another individual, it may be pretty exhaustive. There may be some physical changes that need to be addressed in terms of medication management, maybe some cataract surgery, the home environment. So again, really focusing on what it is about the individual. Symptom awareness, very important that the individuals are keyed into what it is that puts them at risk if they've had a fall. And honestly, we hear this a lot, and I'm sure that those of you on the call have heard this as well. When asked, sometimes people who have fallen will not admit they had a fall. We hear things in our matter balance class. We'll hear things like, "Oh, I just tripped over the whatever," or "I lost that last step." And honestly, I personally did the same thing. I was talking with my primary care provider a few weeks ago. They had asked me if I had fallen recently. And I literally said, "Well, no, not really. I was pivoting on my foot and my leg just sort of gave out and I gently floated to the ground." So I was, even knowing everything I do about falls and fall risk, I was finding myself denying the fact that I had actually had a fall because I didn't want to admit it, right? There's a lot of pride in that. There's a lot of concerns around physical ability, etc. And so I actually laughed and shared that story with the physician that I teach fall prevention. And I was finding myself to be doing the exact same thing that we hear from so many of our class participants of, it wasn't really a fall, but when actuality it was. So being aware of your symptoms, being aware of what it is that can trigger or precipitate that fall is really absolutely key for individuals. Customizing exercise plans, I'll talk about that next, incredibly important. And then really not focusing on just one area. It really is about maximizing prevention in all areas, because again, the key takeaway is fall prevention really is a multifaceted approach to reduce in every way possible every last fall risk factor that you can identify yourself as an individual or in the individual that you're caring or providing care for. So we know from research that the most effective across the board way to reduce fall risk and subsequent falls is strength and balance exercises. There's an incredibly wide array of research studies looking at the different types of exercise, what's effective, what works, what doesn't work, how it works. And we know actually two things, and I don't think I have a slide on this, but for strength, that's obviously an important part of it where, and again, as I said, even though the muscles deteriorate with age, we can still either slow the deterioration or gain a little bit of muscle mass with strength training, right? And so it's not just walking, sometimes it's weights, sometimes it's isotonic exercises, you know, standing, sitting and standing in a chair, up and out of a chair, etc. Just, and core strength, joint strength, core strength, really being conscious of keeping our foundation strong. The other part besides strength, incredibly important, is balance. And I'll talk a little bit about why balance is so important. But again, if you think about, you know, falls and fall risk, losing your center of, you know, gravity and the sort of the upright position, having that ongoing focus on balance is so incredibly important. So this, again, this is not an exhaustive list, but there is a number of really promising evidence-based exercise programs that improve both strength and balance. So yes, things like weight training in the gym, isotonic exercises, again, the importance of working with your physical therapist or your exercise trainer under the guidance of a physician is important. But some of the, definitely the Tai Chis in particular, and there's one I don't have on here, it's called Tai Chi Moving for Better Balance. And there's also Tai Chi for arthritis. And Tai Chi, it rather than being focused more on the strength, it's really focused on the balance portion of improving strength and balance. Honestly, there has yet to be any solid research that backs up my own personal thoughts of why Tai Chi is so incredibly effective at reducing fall risk. And there have been studies with around Tai Chi Moving for Better Balance where they found a 50% reduction in falls among older adults who completed the 6 weeks of this Tai Chi course. And it was, I think, 3 times a week. But my thoughts about this are, and hopefully you'll agree that this makes sense, our awareness of ourself and who we are as a person tends to not age as quickly as our bodies, right? So every day we wake up, our body is 24 hours older, and every week it's a week older. And meanwhile, in our brains, we continue to be our own sense of self and sense of identity, with the exception of people who have some cognitive impairment. We feel like we're the same person, right? We don't feel like we're getting older necessarily, even though every morning we wake up and there's kind of some aches and pains. As we respond to our environment around us, our brain and our sense of self is not always necessarily keeping up with the changes that are happening in our body as we age. So I truly believe, and for those of you that are familiar with Tai Chi, that as you move through the motions of Tai Chi, it reintegrates your self-awareness with the abilities and limitations of your body for that day, right? And Tai Chi is really about the slow movement and the moving your center of gravity and your balance and just kind of reintegrating those. And so I mean, I really feel like it's that just reconnecting our awareness, our mind-body awareness, that then makes us less susceptible to fall risk, in addition to challenging our balance, which is how you increase your balance. Some of the other exercise programs, perturbation balance training, perturbation-based. The layman's term of that is they put a harness on you and push you over, so you're starting to fall, but it catches you. That's more for much higher risk individuals who might be in physical therapy. And then non-traditional, so dancing, obviously within the limitations of your body. Shadow boxing for Parkinson's has been a really effective exercise program. And then there are some virtual reality programs. Safety mobility tips, and I will say, I will make one note that all the research that has been done on walking in and of itself, incredibly important for maintaining your mobility, your flexibility, cardiac. Walking does not reduce your fall of risk if it is the only exercise that you're doing. And part of that is as we walk in an area, and we walk within the limitations of which we're comfortable, meaning as we're walking, we maintain our balance, but we don't push the limitations of our balance. We don't go a little bit past what's comfortable because we don't want to fall, right? And so walking has so many other health benefits for us, but as a fall risk exercise, as an exercise to reduce our fall risk, it has not been shown in research to be very effective specifically for that. That being said, if you are walking, please continue to do it or start walking and do it safely. And here are some ways. So we know that heel to toe walking, oftentimes people are not lifting their toes out enough, and that's where they catch their feet, and the falls may come in there. Scanning ahead, not keeping your head down, looking at the environment ahead of you, and then, honestly, considering walking poles. If you or your loved one or the individual you're providing care for has been, it's been recommended that they use an assistive device. Sometimes people don't like to use canes. I get it, but we always say use your mobility device if it's going to keep you independent, safe, and healthy. Walking poles are a fantastic way to walk safely in uneven surfaces, and honestly, it's got a bit of a sporty look. So we found in our classes that some older adults are far more inclined to use walking poles than nothing at all, or instead of a cane. And then again, just take your time as you're walking and be very aware of your environment around you. One frequently asked question that I have gotten in the series of for the many times that I've done this particular type of presentation is, can you learn a safe way to fall? And honestly, it's usually the men that ask me that question, because maybe they've done judo, or they've done this or that, and they want to learn how to fall and roll. And the answer to that is no. Unfortunately, unless you're black belt, whatever, where you've always instinctively learned to tuck and roll, the most we can do, and so I temper that no with the most we can do is improve our strength and balance, so that we're able to potentially catch ourselves as we're going down, or maybe go down on one knee or leg. But honestly, reflexes are slowing as we age, and oftentimes we'll see older adults who have injuries on their face, and because they're not able to get their arms out in time. So the short answer on that is, rather than spending time specifically trying to train for a fall, put that energy into strength and balance exercises to improve those. So just some general fall prevention recommendations when it comes to exercise is, we absolutely know exercise is the best way to reduce your falls by increasing your strength and improving your balance. The key is to conditionally advance and challenge yourself. So if you are in a exercise routine where it's just the same hum-ho, and you're not pushing yourself within reason and safely, then you're really not keeping up with the aging changes of your body. And so, and again, ensuring that you're exercising under the supervision of a physician, possibly even a physical therapist, within the limitations of your own body. We always tell individuals participating in our Matter Balance and Stepping On classes, if something hurts, don't do it. That's your body telling you something's wrong. But really, if you're doing 10 leg lifts 3 times a week this week, and in 2 weeks it's super easy, next time do 12. And then, if one day you're having some leg pain, cut it back to 5. Really listening to your body and adapting accordingly. Exercising definitely 2 to 3 times a week. And again, this is strength and balance exercises and getting the cardio in there as well. And then monitoring progress. And we always encourage our participants in our fall prevention classes to celebrate accomplishments, because nothing is as encouraging as looking back and realizing that you're able to do just 2 more leg lifts than you were able to do last week, or hold that pose on your tiptoes just 5 seconds longer. And it really does give you a sense of accomplishment and helps you move forward with your exercise. Most importantly, absolutely find a program that works for you or the individual that you're caring for. So some people that may be Tai Chi, some people that may be chair yoga. It may be water aerobics classes, which will help with the strength. That's not necessarily going to help with balance, because the water supports you. It could be, a walking with circuit training at a park. Whatever is going to get you or that individual out in doing the exercises 2 to 3 times a week, Oftentimes we found in our classes that people were more likely to continue on with the exercises if it was part of a social group. So whether it be classes at the senior center, or even now there's so many virtual activities that are available, just exercise-based virtual activities that people are having more access to, whatever it takes, and change it up if it keeps it interesting for you. So moving on to medication, and I won't go too in depth on this in terms of specific medications, because oftentimes for those with multiple conditions or chronic conditions, the medication list is long. But there are a few key points that we know are incredibly important to understand and really consider when you're talking about the individualized fall risk. So just starting with the basics of what are the fall risks associated with medication? Well, we know absolutely that the more medication, the more types of medication that you're on, the higher your risk for falls. And there's a lot of things that go into that, but really it often is that combination of medications and the different types that people tend to be on for multiple chronic diseases. As we age, we know that we become more sensitive to the side effects of medication, and part of this is just reduced body mass. The aging body tends to have less water content, and so once medications go in, they just hit the system a little bit harder than someone who's younger, has younger physiology. And then definitely the side effects of medication tend to be a little bit more notable, or have more effect on the aging physiology, particularly when it comes to drowsiness, dizziness, or blurred vision. And this really is in relation to specific types of medications. So we know, and there's actually a list called, and you can go online and search this list. It's called the Beers criteria, and we're not talking Miller, Bud Light, or Corona. It's Beers was the name of the physician that actually initially created this criteria list of medications, but it is maintained by the American Geriatric Society, and it is a list of medications most commonly used among older adults that have been known to increase or possibly increase fall risk. And so the list will walk you through, is it is it like high fall risk? Is it low fall risk? Should this not be used at all in older adults? And again, this is something that you would want to consider in collaboration with your primary care provider and or your pharmacist. But we do know, and this is again based on the research around, and a whole lot of money and research goes into drugs and drug companies and pharmaceuticals. So lots and lots of publications around this, but we do know that medications to reduce seizures can increase fall risk. Some of the obvious, like opioids, pain medication, anything used to decrease neuropathies. Antidepressants also, because those act on the central nervous system, which can affect or impair not just the executive functioning, but also our vestibular functions. Medications that act centrally on the blood pressure system. So what I mean is they work with the brain to trigger the whole pathway of controlling vasoconstriction or dilation, and heart rate in particular. Those can affect fall risk, because particularly around hypotension, where you stand up too fast and blood rushes down, leaves your head, you get dizzy. Allergy medications, definitely Benadryl. Sleep aids, also so many of the sleep aids that are on the market today actually have Benadryl in them, as do a lot of the allergy medications. And I don't know if any of you can relate to the term Benadryl hangover, but if you've ever had to take a high dose of Benadryl for, say, a severe allergy attack, you kind of know that fuzzy feeling that comes with that. Thinking about that, waking up the next morning or in the middle of the night with that sort of stuffy cotton in the head feeling dizzy, you can imagine how that affects fall risks. So really, it's important to think about when you're taking medications, definitely know what's in the ingredients, because if you're taking NyQuil and you're also taking a Sominex or something for sleep, both of those potentially have Benadryl in it, and you're getting double doses on that, which can be extraordinarily dangerous. In fact, geriatric pharmacists they said the #1 medication, if they can wish that nobody would take it, would be Benadryl. It really is, and it seems like such a benign medication, but it has such a profound effect on the central nervous system, and really is one of those high risk medications for falls. So again, if you have not already done this with yourself or the individual for which you're providing care, really go over that medication list with the physician or pharmacist. And these days, the whole, the Joint Commission mandates around medication reconciliation are much better now at requiring healthcare providers to ensure that medications are getting not only reviewed, but that multiple care providers for the same individual are accessing the same list of medications. So you don't have one care provider, you don't have your cardiac doctor prescribing something that goes against what your neurology doctor is prescribing, and so on and so forth. So everybody should be on the same page. But really talk with a primary care doctor, and actually pharmacists are usually the best because they have such a deeper knowledge of the pharmacokinetics of these medications than physicians do. But ask the 3 questions. What does this drug do for every single medication on the list? What is it supposed to be doing for my body? How should I take this medication? Sometimes some medications are best taken in an empty stomach in the morning, some at night, and so on and so forth. And then most importantly, what problems might I expect from this medication? What are the side effects? And really, are there any medications on that list that are increasing my fall risk to the point that I need to think about maybe changing that medication or reducing it or replacing it with something else? Real quickly on calcium, because we do get this question a lot. And again, these are recommendations based on the National Institute of Aging and the current research. So recommendations for calcium, daily calcium intake for people over the age of 50, for women ages 51 and older, it's 1,200 milligrams a day, for men, 1,000 milligrams, and then men aged 71 and over, it's 1,200 milligrams. So keep in mind, this is total calcium intake over the day. That includes all your nutritional intake, if you're eating milk, yogurt, or cheese, all of that. So this is not to say that everybody needs a supplement. If you're able to get this much calcium in your diet, it's going to be absorbed much more effectively than some of the supplements. We also know that vitamin D3 it's important for everybody for all sorts of reasons. It's tied to reduced depression, fitness. Obviously, calcium is absorbed. You need the D3 to absorb your calcium. And again, here's the requirements, or this is the recommendations for the amount of calcium or vitamin D for people over the age of 50. And again, a little bit in difference is the range. But again, your vitamin D3 can be in the summer, as we know. You can get some of it from the sunshine naturally from our bodies. But oftentimes, care providers will recommend a vitamin D supplement. And again, that's something that we recommend that you consult with your primary care provider. And so and I'll just leave it at that, is talk with your doctor, because some women are going to have obviously higher needs with osteoporosis or osteopenia, that they're under the specific care of a physician in regards to that. Just wrapping up with fall prevention for medications, make sure your medication card is current. Again, reviewing with your physician or pharmacist, avoiding high-risk medication, and ensuring adequate calcium D and vitamin D intake. Last but not least, again, going back to that first slide where I had talked about over half of the fall-related deaths are due to head bleeds, which are commonly associated with individuals who are on blood thinners, whether it be for a stroke or for some type of cardiac arrhythmia. So again, sometimes as we age, there is that decision point where is the risk of falling and having a head bleed, has that outweighed the risk of the underlying need for that blood thinner, whatever that might be. And that's obviously a conversation that needs to be had with care providers. So moving on to vision and what we can do about our vision. And I'm going to run through these slides fairly quickly, just in the interest of time, but more importantly, again, this is so individual. We know that normal vision changes with age. We have that decreased contrast sensitivity between light and dark. So the way that affects us is if we walk into a shadowy dark room, really being able to differentiate can be problematic. Also driving at night. And this is, I mean, you know, visual changes unfortunately start hitting us in our 40s and 50s and just kind of go downhill from there. Loss of peripheral vision. This is just the natural aging process of our eyes. And then medical conditions which can complicate even further, such as cataracts, glaucoma, macular degeneration, and diabetic eye diseases. So just briefly going through, I think everyone is probably familiar with most of these. Cataracts is where the lens become a little cloudy, and there are procedures that can be done to replace those, and very successfully. Glaucoma is increased, and everybody's had the little eye test where they do the little poof of air on the eye. It's where the pressure in the eye, in this front chamber, the fluids in there isn't circulating normally or isn't released and starts to build up, and that back pressure, as the pressure builds up, it can put pressure on the optic nerve and cause damage. And the thing about glaucoma in particular is you don't feel it, it happens, and the only way you can know it about is testing. You won't notice any changes immediately in your eye, and you definitely don't feel any symptoms for it. Macular degeneration, there's two types. There's wet and there's dry. The dry is more common, and it really is associated with the thinning of the macula, the retina on the back of the eye. And then wet macular degeneration is more of a disease process where the vasculature, the blood vessels in the back of the eye kind of burst and bleed. And again, you know, if that's a condition that affects you or your loved one, that needs to be addressed by an ophthalmologist, a specialist. And then similar with diabetic retinopathy, similar to the wet macular degeneration, you get the blood vessels in the back of the eye and the retina will actually can hemorrhage, burst a little bit, and you get this kind of patchy pattern on the back of the retina because that's tissue death back there. What we know about diabetic retinopathy is it is more likely to occur in situations where blood sugars, blood glucose levels are uncontrolled, big swings over long periods of time. And it's because the blood vessels themselves respond to that higher glucose osmotic pressure and will expand and contract and eventually weaken. And that's where they may burst and cause the retinopathy. So vision tips, kind of the basics, just give yourself time to adjust when going from dark to light. Wear sunglasses outdoors just to protect your eyes. The leafy greens actually do help, and probably for anyone who does smoke, the biggest thing you can do is to stop smoking, because the tobacco, the nicotine in particular, and the other substances really affect the vasculature on the back of the eye. And again, keeping blood sugar under control. And it's, again, like I said, those big swings up and down with glucose rather than a sustained high level of glucose that has the more damaging effect. So we do recommend regular eye exams. The newer wisdom on cataracts is get them done early. The procedures are so easy these days, or they're not easy. They're routine, and the equipment in the procedures are so state of the art. It used to be the recommendation was wait till your cataracts get really bad and then replace them, but now they're suggesting you get them done sooner rather than later. And then maintaining good condition of your eye while, you know, as a nurse working in the hospital for so many years. And you know, you may have seen this too with if you're providing care for individuals who wear glasses. They may say they're having trouble with their vision, and their glasses are just really dirty, or the prescription is bad. So making sure that, or scratched up, is tends to be another issue with it. And then another key thing that can be done is increase household lighting. I know some older adults, they're particularly those on a fixed income, keeping electricity bills down is a very important concern. But now with the new light bulbs and high efficiency light bulbs, you can actually have really bright lights for just pennies on the dollar for electric cost compared to what it used to be. So last but not least, moving into home safety, and this is kind of, I guess I'll say, the low-hanging fruit on this, particularly if we have older adults or you are an individual who's lived in the same house for decades. We all tend to collect things around this, and as we get used to how our environment is set up, we may get a little lackadaisical about keeping pathways clear, or I'm just going to plug in this an extension cord just momentarily, and then 5 years later it's still there. And also, if you've been in a house for a few decades when building codes were very different when the house was built, there may not be the safety elements that are available today that can help reduce fall risk. Multi-generational living situations can also cause some other unique hazards when you're talking about particularly toddlers running around, toddlers with toys that have wheels on them, and then living with pets, the small. I used to have a little Shih Tzu who was always exactly where my feet were, always 100% of the time. He would just follow me around the house, stairs and everything. Oh, it drove me crazy. I'd go down the stairs and he would try to run down ahead of me. And so eventually, I was getting concerned about the whole stair thing. So I would pretend like I was going to go down fast and he would try to beat me. So I just stopped and just let him run down. And then I slowly made my way down holding onto the handrail. But yes, it can be a little problematic with the pet. So keeping that in mind. And honestly, when I was cooking in the kitchen, like say Thanksgiving dinner with a lot of people, I would literally put him on a leash and keep him out of the kitchen because I was so focused on other things that it just became a hazard, not knowing where he was when I was cooking in the kitchen. So fall prevention recommendations, just the really straightforward of reducing trip hazards. They talk a lot about throw rugs, the kind that don't have, they're just the slippery on wood or tile. They don't have the mats underneath. Installing grab bars, tubs, showers, toilets, and there are home modification agencies, Rebuilding Together, that can come into the home and do its sliding scale and ensure that the environment is safe, particularly in the bathroom, and railings on stairs. Improving household lighting, talked a little bit about that. And then again, I guess removing trip hazards is the same as reducing. That's a little redundant there. I will talk a little bit about reducing the fear of falling. The Matter of Balance class, which you may have heard about, focuses very specifically on addressing concerns around falling. We don't necessarily like to use the term fear of falling because that's kind of negative, but I think using the term having concerns about falling is valid and a little more empowering. But we do know from research and the science that individuals who are afraid of falling, whether because they have fallen or have had changes in their mobility or their balance, such as a stroke that puts them at increased risk for falls, and now they're afraid of falling, we do know those individuals are at a much higher risk of falling. And there's a couple of things that go into that. There is a fairly common pattern for anybody who's had a big change in their life, whether it's a fall or a stroke or maybe a broken hip, where if they don't manage those concerns that come with those changes in mobility, they will sometimes reduce, self-limit their own activity because they're so afraid of falling. And sometimes what we'll see is individuals, they don't want to leave their house, they don't want to go out, they don't want to exercise, they don't want to be active. And that in turn will actually serve to decrease their mobility further, because we know you have to maintain your exercise, you have to maintain your mobility to keep your mobility and your independence. So as they're reducing, they're self-restricting their activities, they're actually putting themselves at greater risk for falls. And some of it really is just that mental, that fear, and that then feeds into the declines in the body and mobility, and ultimately can end in some pretty devastating situations. So again, the fear of falling may prevent them from the regular exercises. So the Matter of Balance program uses what's called cognitive restructuring, and that's the cognitive behavioral interventions. And what it does is use in a peer adult learning setting, individuals will express or talk about or explore their own concerns of falling in relation to their own situation. And then as a group, at least in a Matter of Balance, as a group, there's a lot there. We then move into some problem solving. Well, what can you do about that? So I don't go to the movie theater anymore because it's dark and I'm concerned about the stairs. Well, okay, let's empower this individual to go early and ask for an usher or somebody that works at the theater to use their flashlight and maybe give them an arm to help guide them down the stairs or into their seat, wherever. And so it's really just ways of rethinking activities that we used to be very comfortable doing that now maybe we're a little less comfortable doing because of the fears of falling, and finding new ways to maintain independence and continue doing what we do and love to do without feeling like we're at increased risk for falls. And again, peer support is incredibly important, and that's kind of that peer learning setting in the Matter of Balance is good. But for individuals who do live at home, developing that I call it social capital, but that social support system, ensuring that you've got people who are, that you're talking to every day, calling you, checking in on you, whether it's Meals on Wheels or just a home visitation or even the phone assurance program, just having that interpersonal check-in can be very beneficial in addressing some of these concerns around falling and maintaining independence and mobility. So last, I wanted to I believe that Simone is going to post this after or provide this as a resource afterwards. But the Centers for Disease Control has developed a comprehensive toolkit of fall prevention resources. And again, by comprehensive, I mean it's intended for care providers, it's intended for healthcare providers, it's intended for older adults themselves. And it's this amazing array of materials, everything from printed brochures to safety assessments in the home, individual quizzes of am I at risk for falling. There's videos in there for both care providers, healthcare providers, on how to do some of the physical assessments around fall risk. So things like the sit to stand, the timed up and go test, the 4-stage balance test. It will actually walk you through how to do those assessments and kind of what the results means and how to determine based on the results if an individual is at typically it's low, medium, or high fall risk and what to do about it. So the URL down there is at the bottom, but really you can just go onto Google or whatever search engine you use and enter CDC and then STEADI, STEADI. And I was telling Simone before we all came on the call, I am not a fan of the acronym Stopping Elderly Accidents, Deaths, and Injuries. That sounds a little tragic, but somehow STEADI itself, the acronym just kind of stuck. So there you go. But Simone will be sharing that resource along with some fantastic videos or access to some videos by the Betty Irene Moore School of Nursing Family Caregiver Institute. In collaboration with AARP, they developed some video tutorials for family care providers on everything from basic wound care to how to transfer a loved one that you're providing care for, to medication management and so on and so forth. So there's a whole array of free videos available on their website, and Simone will be sharing those after the presentation. So last but not least, my contact information. Feel free to contact me if you have any questions. And I know Simone is going to open up to questions here in just a minute. But if you wanted any of the research that I had cited or any of the data or information that I presented today, by all means, please contact me. Email tends to be best. and then I will respond accordingly and give you the information that you are seeking. So with that, I will hand it over to Simone to open up to questions or address any questions that have been put in the chat.
Thank you so much, Christy, for that wealth of information. I feel like this was just such an amazingly comprehensive overview of all of the things to consider, especially for caregivers or care partners on the call today when we think about, fall risk. So thank you. I always learn something new every time we can offer one of these presentations. I'm just so grateful to you for joining us today. We did have 2 questions in the chat. And again, for those of you still on the call, if you have any other questions that you would like to direct to Christy, please go ahead and drop them into the chat so that we can address them. The first, Christy, was, are there any exercise programs designed for both caregivers and care receivers that can improve balance? So something that people can do together.
So, honestly, not specifically that were designed for caregivers and the individual being cared for that I know of. Now, that being said, there may be something more recent, particularly with COVID, and I will do my due diligence and look that up. But I will tell you, I'm just jotting a note. I will tell you that there is an amazing array of fantastic exercises, both video and just through printed materials that can easily be accomplished with both, with the care provider and the older adult themselves together. So the National Institute on Health has, and Simone, I'll actually send these out to you, but there's some really nice, easy to use Institute on Aging, National Institute on Aging, that have some, my brain is blocking the aging page. There's some really nice exercise resources that I can send out to you that you can forward to participants. Absolutely.
Wonderful. The second question was about medications. So are there any specific Alzheimer's or dementia related medications that can increase fall risk?
Oh, absolutely. Yes. And I will, and the names offhand I don't have, but I will tell you that many of the medications that are used to modify the symptoms of Alzheimer's, dementia, and Parkinson's even can significantly affect your fall risk because they work on the central nervous system and can affect, some of your balance and your executive functioning. So again, I'll see if I can find, I know here at UC Davis, they have the Alzheimer's Disease Center. I'll see if I can find any specific research around that that actually comes up with an actual list, sort of like the Beers list for medications in general.
Wonderful. Thank you so much.
Yep, I will send that to you as well.
I appreciate it. And as Christy mentioned, we'll be following up with an email that includes the recording and some of the resources that Christy has mentioned during the presentation. So please look out for that. Another question in the chat, how do I help my spouse who has memory issues keep his assistive device, in this case, a cane, with him? How does the caregiver encourage their care receiver to use devices that will help prevent falls?
Yeah, that's a challenging one, and again, I think that's going to depend individually on the level of cognitive impairment. But the sort of the low-hanging fruit and the easiest answers to that off the top are obviously having it always accessible. Unfortunately, it is a matter of the constant reminders. Sometimes you can, I don't want to say beautify, but if you maybe wrap the assistive device in like some brightly colored tape or something where it's a little more visible. But again, ensuring that it's fit properly for the individual, whether it be a walker or a cane, making sure that they know how to use it properly, which is again something that that should be information provided by a physical therapist, but always having it accessible. And unfortunately, particularly with individuals who have some cognitive impairment, it really is that constant reminder. Sometimes depending on their level of cognitive impairment, you can actually put little notes around the house. So maybe first thing when they get up, there's a sign by the side of the bed that says, remember to get your cane, or, on the lamp, or along those lines. Yeah, unfortunately, it can be the tedious tasks of just constant reminders, ensuring that they're readily available.
Great, thank you. And the last question that we have is about communicating with doctors. So this individual's mom, whom she's caring for, recently sustained a fall, and the caregiver is concerned about the medications that the doctors have her mom on, and how they may be contributing to her mom's fall risk. So I guess, how does a caregiver advocate with doctors regarding medications that could potentially be increasing fall risk for their loved one?
Yeah, absolutely. Great question. So, obviously the first step is to make sure you have a comprehensive list of the medications and the doses and whatnot. But, I think the first step in that, it doesn't hurt to look at the Beers list online and just maybe highlight those medications that are noted on the Beers list to be ones that increase fall risk. The other piece, and as I'd mentioned this earlier in the medication portion, is I strongly encourage, if possible, to make an appointment with a pharmacist. Honestly, sometimes it depends on, sometimes the local family-owned pharmacies are a fantastic resource for this, but you should be able to make an appointment with the pharmacist of your healthcare organization, and just basically say, I really want to sit down and go over all these medications and talk about the fall risk. Once that information is related, then that'll be put in the patient's chart. And then the pharmacist can make note of any medications that are of concern, and then a follow-up appointment with the primary care physician can cover some of those concerning medications and what can be done about either modifying or changing those out.